The annual physical killed my patient. Not the appointment itself, the false security it created. Margaret walked out of her doctor's office last February with a clean bill of health. 6 weeks later, she coded in my OR with 3 blocked arteries her routine checkup never found. She survived, but barely. And here's what haunts me. The tests that missed her condition are the same ones millions of people over 45 still line up for every year, believing they're protecting themselves. They're not. Some of these checkups do more harm than good after a certain age, and the medical establishment keeps recommending them anyway because that's how the system was built. I'm going to show you which 4 I refuse to get myself now that I'm past 45, and why the alternatives matter more than you've been told. I'm Dr. Harrison Chen, cardiothoracic surgeon. 28 years cutting open chests and repairing what goes wrong inside. I've held beating hearts in my hands more than 2,000 times. I've seen what kills people, what saves them, and what the gap between those two things really looks like. Most of it isn't what you'd expect. The blockages I find during surgery rarely announce themselves during standard checkups. The heart attacks I prevent happen because of tests most doctors never order. And the patients who do best? They stop trusting the one-size-fits-all screening schedule around the same time their metabolism changed and their insurance company started covering more procedures. That's not a coincidence. Your body after 60 operates under different rules than it did at 30. The cardiovascular system doesn't just slow down, it restructures. Plaque builds differently. Inflammation markers shift. Your heart muscle thickens in some areas, thins in others, and the electrical pathways that control rhythm become less predictable. Think of it like a bridge that's been handling traffic for decades. The concrete looks fine from the road, but the rebar underneath has microfractures the standard inspection doesn't catch. Then one day, load and time intersect, and the structure fails without warning. That's what happened to Margaret. Her cholesterol panel came back normal. Her EKG showed regular rhythm. Her blood pressure read 128/82. Every box checked. Meanwhile, soft plaque was accumulating in her left anterior descending artery, invisible to the tests her doctor ordered. 70% of first heart attacks occur in people with normal cholesterol. Write that down. Here's the first checkup I stopped getting after 45. The annual fasting lipid panel without an advanced particle test. Standard cholesterol screening measures total cholesterol, LDL, HDL, and triglycerides. That's it. Those numbers tell you how much cholesterol is in your blood, but they don't tell you what kind of LDL particles you're carrying. And that matters more than anything. Small, dense LDL particles burrow into arterial walls like shrapnel. Large, fluffy LDL particles mostly bounce off. Two people can have identical LDL numbers, say 130, but one has dangerous small particles and the other has harmless large ones. The standard test can't tell the difference. It's like weighing your luggage without checking if you packed bricks or feathers. After 45, your particle size distribution changes. Hormones shift. Insulin sensitivity decreases. Inflammation goes up. The metabolism that kept you safe at 35 isn't protecting you anymore. But your doctor's still ordering the same test from 1985. I had a patient named Robert, 52, marathon runner, LDL of 125. His doctor told him he was fine. I ordered an NMR lipo profile, 90% small dense particles, stage 2 coronary disease. We caught it before infarction, but barely. If you're over 45 and you're still getting basic cholesterol panels, you're flying blind. Here's what to do instead. Ask your doctor for an NMR lipo profile or a cardio IQ test. These measure particle number and size. They cost more. Insurance doesn't always cover them. Get them anyway. The information gap between what standard screening shows and what advanced particle testing reveals is the difference between prevention and autopsy surprise. Starting tonight, stop accepting normal cholesterol numbers as proof of cardiovascular health. They're not. The second checkup I avoid, routine resting EKG as a standalone heart evaluation. A resting EKG records your heart's electrical activity while you're lying still on a table. It catches arrhythmias, old heart attacks, and some conduction abnormalities. What it doesn't catch is blockages that only show up under stress, early diastolic dysfunction, or microvascular disease. After 45, especially after 50, resting heart function tells you almost nothing about exercise capacity or real real-world cardiac performance. Your heart behaves completely differently under load than it does at rest, and the conditions that kill you manifest when you're climbing stairs or shoveling snow, not when you're horizontal in a clinic. I've seen dozens of patients with perfect resting EKGs who couldn't make it through a stress test. Their hearts looked fine until we asked them to perform. Then the ischemia appeared. The ST segments dropped. The truth came out. Margaret had a normal resting EKG 6 weeks before her surgery. So did every other emergency case I operated on last year. The test is useful for detecting active arrhythmias or prior damage. For predicting future events, almost worthless. But it's cheap, fast, and billable, so it stays in the annual checkup rotation. Stay with me, because what I'm about to tell you next might make you angry, and it should. The third screening I refuse is the annual full-body executive physical without targeted imaging. You've seen the ads. Concierge medicine practices offering comprehensive head-to-toe evaluations with every scan imaginable. Sounds thorough, sounds proactive. It's neither. Here's what nobody tells you. When you scan healthy people looking for problems, you find a lot of things that look like problems but aren't. Nodules, shadows, asymmetries. Most of them are benign, but now you have to investigate. That means more scans, biopsies, follow-up appointments, radiation exposure, anxiety, and in older patients, the risks of those investigations often outweigh the benefits. After 45, your organs have accumulated decades of minor wear. Tiny cysts, calcifications, hemangiomas, benign growths. None of them will ever hurt you, but they all show up on imaging. I had a 60-year-old patient who paid $8,000 for an executive physical. They found a small liver lesion, probably nothing, probably been there for years, but now we had to rule out cancer. 2 more MRIs, a biopsy. Turns out it was a hemangioma, a harmless tangle of blood vessels. But she spent 6 months thinking she might be dying, exposed her liver to a needle puncture, and racked up another $12,000 in medical bills. That's not healthcare. That's revenue generation disguised as prevention. Here's what works better after 45. Targeted screening based on personal risk factors. Family history of colon cancer? Get the colonoscopy. Smoker or former smoker? Low-dose chest CT for lung cancer makes sense. Strong cardiac risk profile? Coronary calcium score. But scanning everything just because you can afford it creates more harm than help. The human body isn't designed to be transparent. Some mysteries should stay hidden. Now for the fourth one, and this is the screening that still gets ordered reflexively, even though the data turned against it years ago. Annual PSA testing for prostate cancer in men over 50 without considering life expectancy or risk stratification. Prostate-specific antigens sounds scientific. It's a blood test. Simple. Catches cancer early. Except it doesn't work the way people think. PSA catches a lot of cancers that would never have caused problems. Slow-growing tumors that would have stayed quiet for decades. And once you find cancer, even indolent cancer, the pressure to treat becomes overwhelming. Patients panic. Families panic. Urologists recommend intervention, radiation, surgery, hormone therapy. Those treatments cause incontinence, erectile dysfunction, and bowel problems in a significant percentage of cases, all to treat cancers that statistically would not have shortened life or caused symptoms. After 60, the math gets even worse. If you have a life expectancy under 10 years due to other health conditions, finding and treating slow prostate cancer provides no survival benefit. But the test keeps getting ordered because it's on the checklist. I've watched men in their 70s with heart failure and diabetes undergo aggressive prostate treatment for cancers that were never going to kill them, then suffer complications that destroyed their quality of life in the time they had left. The United States Preventive Services Task Force downgraded PSA screening years ago. The recommendation now is shared decision-making based on individual risk. But old habits don't die in medicine. They just keep billing. If you're over 50 and your doctor orders PSA without discussing your personal risk factors, life expectancy, and what you'd actually do with an abnormal result, you're getting screened out of protocol, not out of science. Here's the alternative. Have the conversation first. What's your family history? What's your baseline health? If the test comes back elevated, are you prepared for biopsy, for active surveillance, for treatment side effects? If the answer to any of those is unclear, the test might create more problems than it solves. Starting tonight, stop assuming that early detection always equals better outcomes. Sometimes it just equals earlier worry. Let me tell you what happens in the OR that never makes it into the waiting room conversation. I open chests. I see the damage. And in almost every case, the damage was predictable years earlier with the right tests, not the standard ones. The plaques I removed during bypass surgery didn't form overnight. They built slowly, silently, while patients collected normal cholesterol numbers and clean resting EKGs. The valve calcification I repair in 70-year-olds started in their 50s, visible on advanced imaging, but invisible on routine checkups. The congestive failure I manage post-op almost always traces back to years of untreated diastolic dysfunction that never showed up because no one ordered an echocardiogram with strain imaging. I think about the families in those waiting rooms, sitting with bad coffee and worse magazines, wondering if their father or husband or wife is going to wake up. And I think about the conversations they had with primary care doctors 5 years earlier. Everything looks good, see you next year. Everything didn't look good. The tests just weren't looking in the right places. That's not the patient's fault. That's not even always the doctor's fault. It's the system. The system prioritizes billing codes over outcomes, coverage over precision, protocol over personalization. And after 45, when your cardiovascular risk curve bends upward and standard screening loses resolution, that system fails you in ways you won't know about until it's too late. Margaret recovered, 3-vessel bypass, cardiac rehab, medication overhaul. She went from 4 prescriptions to 2 because we actually fixed the plumbing instead of just managing symptoms. Last time I saw her, she told me something I'll never forget. She said, "I did everything they told me to do. I went to every appointment. I took every test. Why didn't anyone tell me the tests weren't enough?" That question has stayed with me. Because she's right. The information exists. The better tests exist. The protocols exist. They're just not standard. And in medicine, if it's not standard, it doesn't happen unless you ask for it. Here's what you need to remember. 5 things. Write them down. 1. After 45, standard cholesterol panels without particle testing miss the majority of high-risk profiles. Get NMR or cardio IQ. 2. Resting EKGs don't predict exercise-related cardiac events. Ask for stress testing or imaging if you have risk factors. 3. Full body scans in healthy people create more false alarms than real catches. Focus on targeted screening based on personal risk. 4. PSA testing after 50 requires a conversation about what you do with the results before you draw the blood. Don't test reflexively. 5. The checkups your doctor orders by default weren't designed for your aging physiology. They were designed for billing efficiency and legal coverage. You have to advocate for better. Now tell me in the comments, which of these 4 screenings have you been getting every year without question? I want to know if this matches what you're seeing in your own appointments. Because the more people who start asking the right questions, the faster the system has to change. And if this information surprised you, if you've been trusting annual checkups to catch everything, and you're realizing now they don't, share this with someone over 45 who's still assuming normal results mean safe results. That assumption kills people. It almost killed Margaret. Finally, if you want more of this kind of transparency about what actually works in medicine versus what just gets billed, subscribe now. I'm not here to make you comfortable. I'm here to make sure you survive. Your heart has been working for you every single minute since before you were born. It doesn't stop. It doesn't take breaks. It doesn't wait for your annual checkup to tell you something's wrong. The least you can do is make sure the tests you're getting are actually measuring what matters. Quick note before you go. I'm a surgeon, not your personal physician. Everything I've shared comes from 28 years in operating rooms and cardiac wards, but your situation is yours. These recommendations are educational starting points, not medical directives. Talk to your doctor, ask hard questions, push for better testing if your risk profile warrants it, and if your doctor dismisses those questions, find a doctor who doesn't. You're not being difficult, you're being informed. There's a difference. It is never too late to demand better answers.